Yeah. Good morning, everyone, and I welcome you all for this wonderful day today.
Recording in progress.
Good morning, everyone. I welcome you all for this wonderful program, and this is the. Sir, can we mute everyone? Technical team, can we mute everyone? And then I'll unmute. So I welcome you all for this wonderful meeting today, that is PregaTalk. And today is very auspicious day of World Diabetes Day. And coincidentally, it has come on Friday, and we do PregaTalk since last we're doing it since last 3 years. And this is the third cycle we have. And this is the 68th PregaTalk. Today it is in English. For those who are not aware of PregaTalk, let me inform you that this is one of the public awareness initiative which we have started in 2021-22 during my presidentship, and we are still continuing. We finished the first cycle, second cycle, and the third cycle now is also in the verge of getting over now. By the end of this December, we will possibly be able to finishing that. And this is being done in all 22 languages which are there in the Constitution of India. And we have finished practically everyone. This time we have added one new language, though it is not there in the Constitution, but very popular in the Central India, and that is Bundelkhandi. So we just had one program just last Friday of October, that was in Bundelkhandi language. We already have programs on multiple languages, and this we are left with only 3-4 languages which are being scheduled in the month of November and December. So today it is in English, and I'm proud to have Professor Seshaya, whose sir is a founder of DIPSI and Padma Shri awardee 2025, if I'm not wrong, 24 or 25. And sir is a founder of DIPSI, and basically you can say because of him we are all here on this platform. And this education program is his heart, and he always appreciates this program. Our aim is that each and every woman across the corner of the country should be empowered with a good quality education on pregnancy diabetes. They should know there is a condition that called gestational diabetes. They should know that every pregnancy should be screened. They should know that they have to go for good quality nutrition and diet and exercise, how to achieve their targets, and insulin remains the drug of choice, all these things. And if you control your diabetes well during pregnancy, if you screen them early, if you treat them early, we can certainly prevent the development of diabetes in the offspring of diabetic mother in their later life, as well as these mothers who have gestational diabetes. Even they can also be protected through lifestyle modification and other measures from developing diabetes in their later life. So our aim is that we should have education for each and every woman in the country, irrespective, maybe the remotest place of the country, in villages, small villages, in rural areas, urban areas, semi-urban areas, metros. Every woman should be aware of pregnancy diabetes. And like they say, they go and they ask that they have missed their periods, and when they go for the ANC clinics, then they should not just be doing their hemoglobin and blood group and other important tests which are being advised by the OBGYN, but also they should ask for GCT or glucose challenge test, with which you can certainly screen this condition. So early detection, early intensive treatment can really protect future generation. That's the vision of Professor Seshaya, that by the time we celebrate 100 years of independence of this country in 2047, we should ideally not have a single new case of diabetes in India. That's what is the vision. And with this concept, I welcome you all on behalf of DIPSI, Diabetes in Pregnancy Study Group India, as well as Diabetes Care Foundation of India. We have Professor Sheshaya as our presiding officer. We are really lucky to have this time, for the first time in the history of PregaTalk, that we have someone from the global team of IDF has joined, because it's a World Diabetes Day, and we have none other than the president-elect of a global International Diabetes Federation, Dr. Niti Paul from UK, and she is very badly traveling today, being World Diabetes Day. This has she is really very busy, but she could give us the time for 5 minutes to as our chief guest. So we are really fortunate to have Niti Didi here with you. Thank you very much for joining us. And I'm also thankful to Dr. Rajiv Chawla for getting Dr. Niti here on in the PregaTalk, because he happened to be the classmate of Madam, and Madam is now holding a big position there. So we're really fortunate to have all of us to be there at such a global international platform. Madam, if you have time, then we'll ask Dr. Praseshia to speak for 3 minutes. Else, if you don't have time, then we can ask you to speak, and then
may I do this quickly first, and then I can leave because I have another talk to give. But
yes.
Dr. Rajiv asked, so I couldn't say no. So,
Good evening.
Good evening, everybody. Well, good afternoon from England. Thank you very much for asking me, Dr. Sunil. It's always a pleasure to interact with you. I see lots of friends here. Hi, Dr. Shalini. Hi, Professor Sheshaya. It's lovely to meet you today. And it's a great pleasure to be here. Women's health is a great passion and a subject that I have always held an interest in. And I'm so happy that you're joining forces to do these things together, to do these educational content together. Women with diabetes often miss good care, not just women who pre-existing diabetes, but also gestational diabetes and the screening of diabetes. But of course, it affects women at all stages of their lives. So I'm really glad that you're putting out this piece. I wish you luck for the future. I will stay for a couple of minutes, Dr. Sunil, just to listen to Professor Sheshaya. Would love to listen to what he's saying. And then I wish you luck for the future, and hopefully we'll do such talks together with IDF Global in the future. Thank you very much, all of you.
Thank you, Dr. Niti, for being there.
So
Thanks.
Thank you, Dr. Niti. Thank you very much. And let me just inform you that this is we have 22 languages in the Constitution of India, and we are conducting this program in all 22 languages since last 3 years. This is the 68th program, and we do it on every Friday, every weekly. In between, it was once in fortnight. So this is being continued since 3 years, and we are going to almost be finishing the third cycle by the end of December, and we'll continue next year also, madam. So thank you very much once again from all of us, from DIPSI as well as the team of Hello Diabetes. Now, may I invite Professor Sheshaya Sir, Padma Shri awardee and the founder of DIPSI, to speak few words on the occasion. Over to you, sir.
Dear friends, I'm very happy to take part today's program, and I'm going to share with you 2022 when I got that Padma Shri. Next step, I went to Nagpur, Sunil Gupta. I invited lots of people to come and meet me, because that is the time when our Home Minister thought I'm a Karma Yogi. So that I will not leave it. I continue to be a Karma Yogi. Then that is the time I had an idea how we can prevent diabetes. Is it possible? Is there any hope and scope? So this is what I'm showing here today. I was fortunate to meet, to being Diabetes Day, Minister of Health, the government of Tamil Nadu invited me to talk and give me ideas how to prevent diabetes, how to control the country free from diabetes. So in this concept, now I'm so happy, and I got Dr. Anjalashi with me. This is a very unique suggestion. Anjalashi was my student, undergrad student. She was a PG student. I was examiner for her PhD. Is the only lady to this state PhD. So she has come today, and I am sitting with Minister of Health I discussed with him and I told her how we are going to approach this topic. It is, I'm sure, I'm extremely happy to share with the doctors who are listening to this contact. She will explain now. This is the government of Tamil Nadu approved this concept again about the prevention of diabetes program. That's what we call open scope for prevention of diabetes. Oh, Anjala, you can tell him.
Good evening, everyone. Actually, we were fortunate during the celebration of the World Diabetes Day by the government of Tamil Nadu. They have declared this primordial prevention of gestational diabetes, and the protocol goes like this. That is, we have to screen all pregnant women at 8 weeks for the early gestation glucose intolerance. So there, if the PP blood sugar is less than 110, probably the individual is normal. If it is between 110 to 190, then she has an early gestational glucose intolerance.
Very important. This is very important word. Eggy.
It is called eggy. So, and if the PP blood sugar at 8 weeks is more than 120 milligram, then the patient should be a potential GDM patient. So, they require a OGCT screening and they go into the protocol for the GDM management. So, if she is in the early gestational glucose intolerance group, to prevent the GDM, we have the means of medical nutrition therapy, lifestyle modification, and also the metformin drug, where we use 250 milligram of metformin twice daily. If the blood sugar is, and our aim is to keep the blood sugars, that is postprandial blood sugar, between 110 to 190 throughout pregnancy. And she has to continue the metformin till delivery. Suppose if it is more than 190, then we can increase the dose of metformin to 500 milligram BD to the maximum of 2 grams. That is left to the consultant desire, their choice. Okay, and by this, by the identifying the eggy and keeping the blood sugar below 110 throughout pregnancy by means of medical nutrition therapy, lifestyle modification, and metformin prevents the GDM in the mother. So this is the protocol they have approved, and the government of India government of Tamil Nadu, and they are going to do it in all government institutions. Initially, about 5,000 pregnant women will be screened, and slowly they will follow it up. So this is the one discussed today, and Sir is very happy to give this in this August audience. Thank you.
Thank you, Sunil.
Thank you very much, sir. Thank you. And now we are all really excited to have wonderful results. Early results are really in favor of prevention. And we have few data which have come from few of the centers through the pilot study. And sir, we are all really waiting for the bigger data to come and then get it implemented across. With this, let me now invite my esteemed panelist here for this talk. Madam, can you just unshare this screen if you don't mind?
Yes, we'll do
friends
it.
Here, I am going to another word, message
Yes,
I want to give to our colleagues here. Focus on the fetus for the future. That is our message to everybody. Focus on the fetus for the future. Hope everything is there. And I am told Rajiv Chawla is here. He is going to study. And our Shalini is here. She is another, excellent speaker. She will spread to everybody. And then other people who are here, I'm thankful for them for coming over here. And again, I'm thanks and I wish Sunil for inviting me to start this program today. We'll go on that so that we can prevent by 2047, this country may avoid diabetes. Thank you very much, Sunil.
Congratulations, Dr. Sunil, for continuing this public awareness program of PregaTalks. So you can disseminate this, whatever we said, no, that the early gestational glucose intolerance training, that can be disseminated to all people, all public.
Yes, ma'am.
Thank you.
Thank you.
Thank you. Thank you very much. And now we have this open forum. We are starting now this particular session, which is a public awareness program on pregnancy diabetes. And we have none other than, I'll just introduce my faculty here. They are They are like a core group DIPSI people here. We have our esteemed past president of Diabetes and Pregnancy Study Group India, as well as the chief editor of IJJDC and past president of RSSDI, Dr. Rajiv Chawla from Delhi. Sir, we welcome you. And then we also have Dr. Uday Thanawala, who's a very senior gynecologist from the city of Bombay, and also hold multiple positions in the OBGY. And then we also have Dr. Shalini Jaggi. Shalini Jaggi is the current president of DIPSI, based at Delhi, and very enthusiastic speaker here. And then we also have Dr. Hema Divakar, all the way joining from Pune. She has been felicitated today as one of the past president of Foxy with the Kamal Patra Award or something like this, I was told. So we welcome you, Hema. It's very difficult to get date, Hema. I had to wait for 12 hours to talk to her yesterday. So,
congratulations, ma'am.
Congratulations, madam. Even
Congratulations.
to have her reply on WhatsApp, it takes 24 hours.
yes. So,
He's so busy.
What a fantastic introduction.
but important and whenever
The time lag helps for things to sink in.
but then the important is for those who are listening to this particular PregaTalk, the moment you need madam, she is always there throughout. This is my experience since last 30 years almost. Since 20 years at least, madam, we are together working in DIPSI, and I have seen you working left and right across, and she'll be always there to guide us. So we welcome you, ma'am. And we
Thank
also
you.
have,
Thank you so much.
madam is a very senior gynecologist. She's from the city of Bangalore and the past president of Foxy, and currently also holding one of the international position in the FIGO Fed, yeah. And she was one of the trustee, or she was one of the position chair of one of these committee in FIGO, and she was vice president also, if I'm not wrong, of FIGO earlier. So, madam, today there's some another position you have just written it. So we welcome you on this platform, and we also have our dietitian.
Sunilji, that shows that positions don't matter; people do. So I always honor your request. Thank you so much.
Thank you, ma'am. Thank you very much. And then we also have Dr. Kavita Gupta. She's an only nutritionist here. So most of us, we are very superficial in diet and nutrition, but she's there who has in-depth interest in pregnancy diabetes, and she will be able to guide us on nutrition. So without wasting much of the time, thank you very much, Professor Shreya sir, for joining us and giving your advices and newer thought processes. We are really overwhelmed. So let me start with Dr. Rajiv Chawla sir, because he's the person who has made guidelines for DIPSI, along with Dr. Hema, Uday Thanawala, myself, and Shalini. All of them are part of it, but he was instrumental getting it updated in 2024. Dr. Rajiv Chawla, but this particular program is being listened by many doctors, and it will be available on this link throughout, even in future. So all of us can put it in our clinics also for the public awareness interest. And today being World Diabetes Day, what is your take on this? What is the current situation of this gestational diabetes? Why are we so aggressive to have the education program on this topic? 68th program, and different languages, almost every languages we have done 2 or 3 programs. So there's a third cycle. So why it is required? What is the situation of GDM? What is the burden of GDM? And what will happen if you don't treat it on time? Over to you, sir.
Good evening, everyone. Thanks, Dr. Sunil, for this opportunity to be part of this very, very important show year after year. And I really salute your passion for patient education, which you have been doing through PregaTalks year after year. And this is the third session and 68th program in different languages. And we are happy to have amongst us Professor Hema, Professor Sheshai sir, and Neeti just addressed the meeting. And sir and you, in fact, already said that today it is very, very important to address the issue of women health above all. Today we know that women were always important. Today they are even equally or more important, not only as a younger sister, as a friend, as a wife, as a mother, and as a caretaker of entire family. So their health is going to be extremely important to all of us. And we know that, as sir very rightly said, on one hand, we are focusing on fetus for the future. And you said, and sir also said, that by the time we complete 100 years of our independence, Modi government and Ministry of Health and Dr. Jitendra Singh, they have vouched and pledged that we will try to have health for all. And there also in that DIPSI meeting, we said that if we today adopt what is Sir's dream of primordial prevention and screen pregnant women at 8 weeks as earliest, not traditionally at 12th or 13th week, maybe we may be able to intervene and we might be able to prevent hyperglycemia early in pregnancy. Aggie and offsprings will not be exposed to even lightest or mildest degree of hyperglycemia in early pregnancy. So that will prevent hyperinsulinemia developing in the fetus. And for, it is likely, we today hypothesize that if we intervene early at 8 weeks with MNT and if required with metformin, maybe we might be able to prevent hyperglycemia not only in the mother. Subsequent development of GDM will also be checked, and these offsprings born out of this index pregnancy will not develop NCD after 25 years. So that absolutely matches our vision of 2047, that if we intervene early with the screening and intervention both. And good thing is Dr. Anjalakshi is there and Sir is there. They have already proven that from Chennai. And just to share with you, we just submitted our manuscript from Delhi, led and convened by Dr. Pikky, that if we intervene at 8 to 10 weeks with low dose metformin, not only we have prevented onset of GDM in those pregnant females, but we also prevented sensitization of those offsprings versus hyperglycemia. So I think this initiative is very, very good. This is a very, you may say, I exclude that, and you are sort of championed this art of patient education to spread this message of gestational diabetes screening early through these programs. And I'm sure every listener, doctors, or any person or any female, whosoever are logged in today, in their family, if they have a pregnant female, they must screen them early for prevention of hyperglycemia. So on this World Diabetes Day, this becomes a very, very core message that it is the women health which will go a long way in prevention of NCD and subsequent risk of type 2 diabetes and non-communicable disease.
So we understood that we are protecting actually two generations, the mother as well as the child. And if you want to really protect your future generations, we have to focus pregnancy. That's what is a very strong message. And it is a universally accepted fact. And this hypothesis has been endorsed by multiple organizations and multiple recommendations. Now let me go to Shalini. Shalini, now we have understood that how do we what is the importance of gestational diabetes. But when it comes to screening, what is the simplest way of screening? Whether I have three questions, Shalini, for you. Who is supposed to be screened? When they are supposed to be screened? How it is supposed to be screened? And how will you diagnose it? Yeah, over to you.
Sure, sir. So who to screen? I think every pregnant woman needs to be screened. Ideally, the screening should be done pre-conception to rule out any pre-existing diabetes or pre-diabetes for that matter. However, if that has been missed, the first screening should occur at the first point in contact in pregnancy, so that is the time when organogenesis is happening, 6 to 8 weeks. So that is exactly when the first screening should be done to pick up any pre-existing hyperglycemia or early GDM, as has been discussed. And then if that screen test is negative, repeat screening should be done in the second trimester and then the third trimester as well, because we know that Indians, Southeast Asians, we have a very high risk of GDM. So that is why I think at every trimester, a screening must be done starting from the first point in presentation in the first trimester. Now, who to screen is clear, universal screening for all pregnant women. When to screen, I've explained. How to screen, earlier there were a lot of controversies. You do a GTT, ask her to come fasting, then you do a fasting test, then you make her drink 75 gram glucose, then you do a 1 hour value, she keeps sitting there, then you do a 2 hour value. So these things, okay, in a tertiary care center in a city where a woman has time, can be done, no problem. But the problem is most of the women are dependent on husbands or somebody or the other to bring them. Half of the time they cannot come fasting early in the morning. Then sitting there for 2 to 3 hours becomes difficult. So that is where now the Government of India, Ministry of Health, Family Welfare, FIGO, WHO, IDF, everybody clearly endorses. And now in India, what we follow is the DIPSI guidelines, which clearly tell you that irrespective of whether she's had a meal or not, whatever time she comes to you in the antenatal OPD, all you need to do is just give her 75 gram glucose in 300 ml of water to be taken over 2 to 3 minutes. She can drink that. And then exactly 2 hours after that, with a standardized plasma glucometer. So even if you are sitting, in a primary health center in some village in a tier 2 tier 3 city, a simple standard glucometer, all you need to do is just do a capillary blood glucose test at that time, 2 hours after she's taken that 75 gram glucose. And if that value is more than 140, you diagnose GDM and accordingly put her on the GDM care pathway. So it's very simple. One single test that can be done anytime, irrespective of whether she's fasting or whether she's had her breakfast or whether she's had her meal, lunch. So even if she's coming at 4 o'clock in the evening, all you need to do is give her 75 gram glucose, and exactly 2 hours after that, just do a finger stick. And with that, if it is more than 140, you know this is a woman with GDM and needs to be cared for accordingly. So I think who to screen, universal screening, all pregnant women, when to screen, beginning of pregnancy, second trimester and third trimester, and how to screen, DIPSI single step test.
So now we have practically diagnosed. Now, Dr. Uday, I have a question for you. See, basically every women, once they miss their menses and whatever, whenever they're planning a pregnancy, they will never ever come to us unless until means they are known type 1 or type 2 diabetes. They will not come to us. They will only come to a OBGY. So you might be coming across such examples very often, that someone comes to you, gets the random blood sugar done, someone has come with the urine sugar done, someone you see a report where the pathologist has given 160 as normal because it's written up to 180 as abnormal, something like this. So it is like it is sometimes very difficult for them to understand. So what difficulty you face while, and what's a very clear message, and then I'll immediately go to Hema, that what kind of therapy we will start for once we diagnose it.
So what I understand is you are telling me if there was a patient already with a random sugar or something done, do you do a DIPSI test again? Is that what
Yes,
you're saying? Well, in
yes, yes.
general, yes, because what we want to test is whether the hormones of pregnancy have any effect, and make the woman glucose intolerant. So unless you give a glucose challenge, we will not come to know whether the woman has become glucose intolerant. Then, of course, there are ranges. But, like, suppose if somebody comes to me with a fasting of what, 190 or 200, then no, then I will probably not give her a glucose load. And I will say, just do your fasting and post lunch and let us see whether you are in the range of diabetics or not. So, it will all depend on what range or what method she has come with. Now, many people say that, okay, HbA1c, let's do as a primary screening method. And I would still say that HbA1c is a thing, especially in the first trimester, very important if you want to know what is the glucose control in the last 3 months. But in general, in pregnancy, what holds more and what gives you a more sensitive pickup is the 75 gram glucose test done 2 hours, whether in a fasting or a non-fasting state. And if the level is more than 140, we label them as a gestational diabetic. That's it.
Hema madam, now let me come to you. We have heard about these little much more onto the long-term complications on the baby and mother. But there must be some complications which you might expect being a mother with gestational diabetes. So once you label it, what are the maternal complications we see, and once they're diagnosed, what is the first step will you do? Will you go to a nutritionist? Will you send it to Shalini for the treatment? Sometimes you can send it to me also if you want. But and or you will directly start your own drugs and do it. So what are the steps? How do you follow this such case?
Yeah. Thank you, Sunilji. First of all, before I just take a minute to answer your question, I would rather like to say that many times we doctors in various meetings, CME programs, etc., just discuss, agree to disagree, and all the things happen. But how will it go beyond the four walls and reach where it has to reach? It has to reach every girl, every woman, every family, every community, and the messages that you are giving out through the PregaTalk program, reaching to everyone out there. Heartiest congratulations once again. Now the question of, if all of you who are listening to this can imagine, what will Sunilji be calling Kavita in private? Sweetheart. Sweet disease today is a heart disease tomorrow. That is the concept that we were trying to drive ahead to the entire community, because the complications to the mother, complications to the baby just do not begin and end with the pregnancy. It goes on from, for her lifetime and for the next generation also. And that is why what the meets the eye in a narrow span is something which is of significance, but what tsunami it will bring about in terms of entire population being hit by a tsunami of diabetes or cardiac diseases, etc., is a huge problem. Now, first, let me just very briefly tell you what can happen to the pregnant mother if her sugar is high. First of all, it's a silent problem. So she will not even know unless we test. That's why, as Shalini said, pehla kadam. Take the first step in this long journey. Do your testing to see what your sugars are like. So if it is high, why do we as doctors insist that you should do this, that, and the other to see to it that the sugars come to a normal phase? Again, I quote Dr. Sunil Gupta, who says the baby should never know that the mother has high sugars, which means what the mother has to do, she has to do something to control her sugars so that the baby is not exposed to a high sugar environment. Because if it is exposed to a high sugar environment, right from malformations, that is abnormal formation of various organs, if it hits it right in the early first 3 months, or the abnormal growth pattern, and moving ahead, the increased water content around the baby and premature labors, and the chances that this baby will be uh, admitted in the neonatal intensive care unit with respiratory distress or a lot of other problems with low sugars in the baby as soon as it's born. So there's a chain of things that we as gynecologists are bothered about the baby. But what about the mother? The mother too has what we call comorbidities. It is not only sugar alone, but hand in hand, the chances that she becomes more obese, gains much more weight, and she has more chances of developing the high blood pressure also in pregnancy, more chances of having a lot of bleeding or hemorrhage because of the uterus being overstretched, and also chances of having a cesarean section, the wound infections, and difficulties in breastfeeding and whatnot. So there is a series of problems in the short term. That means pregnant mother, immediately at delivery, immediately post delivery, both to the baby and the mother. But the long term, you should always keep track of this lady forever and ever in her life, because once she has demonstrated her sugars are high in pregnancy, there is every chance that it will again become high in the next part of her life, maybe in 2 years, 5 years, again during her next pregnancy, etc. So don't please lose track of yourself when you are tested with high sugars in pregnancy. Continue to do the testing annually, because type 2 diabetes and heart problems should be stopped. The child also, at birth, yes, it is of greater weight and a lot of other problems that I have just brought it to your notice, but the childhood obesity, 10 years old child and it is having morbid obesity already, or early 20, 25 years the child is, but already getting into a phase of diabetes and other problems which are typically expected after 40 or after 50, all of these. So there is a whole tracking. It is not one, but multiple. It's from generation to generation. So the pehla kadam, the first step of testing either before pregnancy or during early part of the pregnancy, and keeping the sugar under control forever and ever. Last 1 minute I will take. What do? Don't scare the women. reassure them and the family there is a problem, but it is a problem which can be solved. It can be solved by the lifestyle changes, that is low carbohydrate diet and certain other instructions that we'll give. Yes, we can send it in today's day and age with technology. We can send it to Kavita, we can send it to Sunilji, Shalini, Uday, anybody across the globe. They, in their own language, they can explain what to eat, what not to eat, etc. Not only during the pregnancy, but ever after. They have to be cautious about the diet. Diet control is the cornerstone. Medical nutrition therapy is what we'll call. If it's not under control, you're anyway repeatedly going to chase her sugars to see to it that it's normal. You start giving the tablets which are allowed and safe in pregnancy. If that also doesn't control, then you have to switch to insulin. For that, we definitely need to lean on specialists like Rajiv ji and Sunil ji and the diabetologists in the country who really have guided us very, very well about what to do and why to do whatever we do. So there is a whole range. The problem is there, but please, please, each one of you remember that the solutions are also there and your health is truly in your hands. So you have to also take some responsibility for maintaining your sugars in the normal levels for the benefit of both yourself and your baby, is what I'd like to say all the viewers.
Thank you, Hema madam. As usual, you were aggressive enough to, really shock people that, yeah, you should be doing very, very aggressively on these lines. And of course, the Pehla Kadam is one thing which I have heard you from you multiple times. I really respect it. So Kavita madam, now, yeah. So Kavita madam, you now patient has been diagnosed. We have now women with GDM. You have different kind of people here. You have one type 1 diabetes who is planning for pregnancy. I feel such patient, Dr. Rajiv sir will be able to guide us that how should we plan preconception counseling and care in those who are type 2 diabetes or those who are already type 1 diabetes. There are more and more young women now getting detected, and that is going to be a challenge. So before I come to Kavita, may I just request Dr. Rajiv sir. Dr. Rajiv sir, are you there? Okay, so Shalini, let me and you finish this off. If someone has already known type 1 or type 2 diabetes, what they should do is they should go and meet their doctor for the planning. And this planning will be that you should achieve a good glycemic control. Your HbA1c should be ideally less than 6 before getting conception. So it should be ideally 6, up to 6.5 is acceptable. For those children who have higher risk of those type 1 diabetes, who are at higher risk of developing hypoglycemia, they can even keep it up to 7. So that's the first thing. Keep your fasting blood glucose less than 90, 2-hour post-meal blood glucose less than 120 on safe drugs. Those who are type 2 diabetes, they have to change their oral drugs and switch over to insulin. And some of the people may need metformin along with insulin therapy. And they can, once they achieve your target, you can certainly talk to your doctor and say that my targets are achieved. Second thing is you should also be evaluated for all the vasculopathies. Vasculopathy means you have supposed to be looking into retina, your kidneys, your heart, your liver, your other complication, nerves, and all these complications have to be seen in the women before you are planning for pregnancy. And if you have some complication, that is to be properly tackled, and a proper drug should be given. If you have blood pressure, hypertension, then the drugs to be chosen properly. For diabetes, whatever the best drug we give are contraindicated for pregnancy. So you have to withdraw those drugs and go for the safe drug. Remember, by the time you diagnose your pregnancy, your baby will always be of 6 to 8 weeks old, and your baby will get exposed to either high blood sugar, all these drugs which are not safe for the baby. That is why before getting conceived, you should go to a doctor, go for achieve good control, achieve weight control also, try to get your weight reduced. If you're obese, try to and get your all investigations done. And thyroid also one thing that you should be checking it. Once all the parameters are good, then Shanilin will give you, oh yes, you are fit for pregnancy. So like you get fitness for hernia, for appendix, for cataract, similarly you should also have a fitness for pregnancy from your doctor. That's the first message. So madam, now Kavita madam, I'm coming to you. You have either type 1 or type 2 or GDM, which is just appearing in pregnancy and going to disappear after delivery. How do you plan your diet from the first trimester to delivery, to the first, second, and third trimester? We'll talk lactation little later.
Yes. So first of all, first we need to understand that if the BMI, the pre-pregnancy BMI is normal, then we need not increase any calories in the first trimester, and only in the second and the third trimester is where we will increase an additional calories of around 350 kilocalories in the second and the third trimester. We also need to understand that the lady, the pregnant woman, is really being pampered by the entire family, and she's being forced to overeat. So here we need to understand that they should not be forced to overeat. They must concentrate on stepping up on nutrient dense foods rather than energy dense foods, as per their RDA. That's important. And as per the ICMR NIN guidelines, let me tell you that a minimum of at least 175 grams of carbohydrate is important for the fetal growth. So any sort of any restrictions in the macronutrient or any sort of, especially in the obese woman, obese pregnant woman, no sort of dietary restrictions are recommended. Secondly, we must make sure that a protein is added in every meal. That is important so that we can blunt the spikes, especially the postprandial spikes. That's very, very important. And in additional, again, in the second and the third trimester, we need to increase or step up the protein. So that will be around 8 to 10 grams in the second trimester and around 18 to 20 grams in the third trimester. And we need to focus on complex carbohydrates. So all the simple carbs, so your sugar, jaggery, honey, has to be totally stopped during the GDM pregnancy. And we need to have a well-balanced, nutritious food, which is low glycemic index, and especially comprising of good quality proteins and fats and fiber. That is very, very important. So when we talk about protein here, I think the best thing is your pulses, legumes, nuts, milk and milk products, egg white. What we have seen that having an egg white, especially in the morning breakfast, will not spike your postprandial blood glucose, or even splitting of meal is something which is really advised for a pregnant woman. So rather than overloading of carbohydrates, having your upma or maybe your poha. Especially I come from a central India where the breakfast is mostly poha. So having a lot of poha and then having a hyperglycemia is not recommended. So rather we can add protein or split up your meal. That is the way how you can manage your postprandial spikes. And in fact, adding more of fiber, salads, sprouts, nuts is something which is recommended for especially in a pregnant woman.
Good. So, Kavita, you have already alluded to the medical. What about your artificial sweetness? You talk too much about, because our women, there is little issue of, amongst OBGYs. Many of them they don't like it. Many of them they
Yes.
want that their GDM.
So that's always a controversial topic, and it's always, I think even we dietitians do not recommend much of artificial sweetness. But however, FDA has approved few artificial sweeteners like aspartame, sucralose, stevia, and acesulfame potassium. And but however, it can be taken. They have a acceptable daily intake. They can be taken. But however, we as dietitians do recommend, if we can forego these artificial sweetness in pregnancy, it's well and good. If they feel like eating something sweet, so they can go maybe for, natural sweetness like your kishmish or anjeer can be taken. But again, monitoring is very important.
I fully appreciate that we should always encourage the natural sweeteners, which are not going to increase the blood sugars, as well as have your satiety.
Even a fruit, a small fruit can be taken. But again, fruit not with the breakfast. It can be taken as a mid-evening snack, and that too a citrus fruit, which will be rich in fiber and rich in vitamin C. So such type of fruits can be taken in the mid-evening, say maybe around between 4 to 6 p.m.
Kavita, ma'am, one question that a lot of patients ask is now when the winters are coming in, because earlier it used to be good. Now we tell them not to have jaggery. So dates, date laddus, date mithais, everything is available. So please give us a comment for all our patients who think that they can have dates, so they start having a lot of date laddus.
That's what I said. So dates laddus or dates mithai or anything cannot be taken much in quantity, because again they will raise your blood sugars. Of course, they are rich in vitamins and minerals. However, they will again raise if taken in large amounts, because they feel it's dates बिना शक्कर का है, हम ज्यादा खा सकते हैं. But again, I would emphasize, I always tell all my GDM that please monitor whatever you are eating, please write there so that you understand that that particular food is giving you a spike in your food.
Absolutely.
Now, Shalini,
Sir, can you guide us that when it comes to glycemic index of dates, not as a sweet, any sweet created out of dates, can we allow giving them 1 or 2 dates in the daytime, maybe after meals, after lunch or after dinner? Most of the North Indians, they want to have something
sweet.
If you tell them not to take jaggery or anything or any sweet, they will say that, can I have a piece of date or no?
No, sir, not immediately after meals, not at all. Evening, maybe if they want to take, but then again, if they want going for a walk or something, that time they can have a half piece of a date. That time is still fine. And if they have it with the nuts, that is still better, but better avoided again because it would spike their blood sugars.
So Shalini, now we have finished with diet. We have now finished with can you just highlight very few, hardly 1 minute, if I can give you for exercise, or maybe if Uday is there, Uday, can you just talk, because exercise is one area where gynecologists have to advise exercise. Uday, can you just tell what kind of exercise you, and which are the women who are supposed to be asked to go for rest, taking rest, and should not do exercise? Do we have such kind of thing? Yeah.
No, sometimes when there are pregnancy complications, rarely we have to advise bed rest, but generally bed rest is not recommended for most of the major problems which come up in pregnancy. And exercise is a must. We say that you have to be active and do exercise, and you need to do 20 to 30 minutes of exercise every day. But some women, it's not very easy to do it. If they're working or if they've got a lot of housework to do, then a simple thing to do is that after every meal, by the clock, walk for at least 10 minutes, even if you walk in the house. So that would help a lot to bring down the sugars, the postprandial blood sugars, to a better level. So that much exercise they have to do. And if possible, they have to add another activity or another exercise regime to their sugars. And if they're doing self-monitoring of blood sugars, they'll be very happy to, like what Kavita said or what Shalini said, they know what is spiking their sugar, and that is how even after exercise, what does the sugar come to with exercise, without exercise, they'll be able to judge. But the simplest thing to tell them is that, okay, 10 minutes after every meal, do walking, even if it is walking in the house. And that's what we used to do even in the COVID times.
Hema, before you leave, can you just highlight the importance of sonography in hardly 30 seconds? How best we can we can suggest, because there are a lot of USGs screenings are done throughout the pregnancy in GDM.
Yeah. Sure. See, this is one thing which the patients always want, and they're more than willing to offer themselves for any number of sonographies that we ask. Apart from the standard sonographies offered at 12 weeks, 22 weeks, and at term, in these kind of patients, we want to especially keep track of the anomalies or abnormalities. So an early anomaly scan is quite in order, and high resolution with some specialists, to do the earlier scans, so that if there need be, we can change the course of a further management. Apart from this, we do advise the fetal echo, which is a study of the heart of the fetus. because there are likelihoods of abnormalities there as well. And then constantly we have to track the growth of the baby, whether it's going on the usual scale, and as expected, if the sugars are not under control, it will go on a higher scale. But sometimes it can drop its growth, which again signifies that now the blood vessels supplying the baby are also getting narrowed down because of a severe form of the disease, the vasculopathy as we call it, and then it may impede the blood flow from the mother to the baby. So this is not the typical case. So the Doppler studies are also something that we add, and the water content around the baby, as I told you, it's called the amniotic fluid index, that also needs to be studied. And last of all, the expected weight of the baby, because that helps us beyond our clinical examination to take certain decisions about the time and mode of delivery. So all of these, so scan, as Uday has always called us, the sixth sense of the OBGYNs, it always adds and complements many of our dilemmas and complex decision making throughout the pregnancies, right from the start until the finish point. Thank you.
Thank you, ma'am. Now we have now practically screened everything, and now the patient is in good follow-up with nutritionist, the OBGY, and now they have tried some drugs. So let me think of asking a question to Dr. Rajiv Chawla. Sir, which are the drugs which are being given? We have our targets. Targets are very stringent target. We have tried to achieve fasting should be less than 90, 2 hours should be less than 120, and we should be monitoring our blood glucose, fasting, post breakfast, post lunch, post dinner, very regularly throughout the pregnancy. So maybe 6 times monitoring per day. So Rajiv sir, can you just highlight the drugs which can be used in pregnancy diabetes? Will be very brief, right?
Yeah. I think once it comes to
we also have sir,
Bansi, yeah, we welcome
Bansi, yeah. We also have Dr. Bansi Sabu, who is the Southeast chair of IDF, and he is one person who's always there for such education program. He's already conducting one program for IDF currently from 7 to 8. Still, he has joined us. We really welcome you, Dr. Bansi Sabu sir, for your presence. And you are one of the person who has already supported education for the people, especially in type 1 diabetes. So we really welcome you as a Southeast chair for IDF, and we expect you to speak for a few words before you leave, please. And then
thank you, Sunil,
yes,
for kind words of introduction. Happy World Diabetes Day to everyone. This year, what I was doing a program with IDF Southeast Asia, inviting Dr. Niti to launch a Blue Circle Clinic. A Blue Circle Clinic project, which I have thought of before 1.5 years, discussed with Dr. Peter, that all those clinics from primary care to tertiary care center, like recently Dr. Rajiv Chawla opened, and you have like tertiary care center, they can have 3 circle of blue color, and someone who is just practicing at a one small center taking care of people with diabetes, they can be given even a primary care, and in between intermediate care, like a secondary care, which we can say can be given even 2 circle. That was the plan of giving a Blue Circle Clinic project, which we launched from Southeast Asia. And today what I launched is intent to become part of it. So, not a full program. When you can become the part of Blue Circle, that will require a long form to fill. It's like a full-fledged filling a form and then improving your care. And the ultimate idea is to improve the care for people with diabetes. So I thought the World Diabetes Day will be the ideal day where we can have this Blue Circle Clinic project. So what we launched just before some time with all our leaders from Southeast Asia, all active members, all senior members, all past president, past chair, not only from India, from Bangladesh, Nepal, Sri Lanka, Maldives, from where. And I congratulate Dr. Sunil Gupta. He is one man who is doing a lot of education program. I have not seen a person who is there on a radio, on television, on newspaper. And not only he is there, he also bring all his friends on the newspaper. Next day, you get your photo on Maharashtra Time, on some Nagpur Times and Lokmat Times. I mean, that really surprise you, but you get that's multiple education program and a busy practitioner that I know because I visited his center, and he's taking care of people from pediatric to geriatric. Every age group patients are there in his clinic. He take care of a lot of type 1 children, lot of type 1 adults, lot of people with uh, adult geriatric patient. I know some of my relatives in Nagpur who are taken care by Dr. Sunil Gupta. So I know, very dedicatedly who's taking care of a lot of people, and his interest and passion is always there with pregnancy with diabetes. And I know Kavita, I know Uday and Shalini, all of them, and along with Rajiv Chawla, they all are part of the program for pregnancy with diabetes. So they all have that interest. But he is the one who is taking care of every aspect of diabetes and a lot of education program which he is doing. From as a Southeast Asia chair, I congratulate Dr. Sunil Gupta and Dr. Kavita Gupta for their center and the number of programs which they are doing for diabetes care and for education. Education is the key to improve the care for people with diabetes. So I congratulate. And this PregaTalk, which he started long back when he was chair of DIPSI, now currently he is president-elect of RSSDI, one of the biggest organization of diabetologists in the world and very key organization from Southeast Asia. So I congratulate that he is continuing to do this PregaTalk, and I'm sure in RSSDI he will involve many more doctors from the country, and he will continue this education program in the country more and more under the leadership of him in RSSDI. Thank you once again, Sunil, for inviting. Thank you.
So thank you very much,
Thank
Bansi.
you.
Thank you.
Thank you, Dr. Bansi, for words of encouragement and your presence on this dais, virtual one. And I'm sure Dr. Sunil, of course, no words will suffice when it comes to a passion. What he has for patient education program it is remarkable. So we salute his passion, and every time he gets us on this virtual dais for a education program, we have always been there. So back to science, Dr.
Bansi, we already had Bansi, we had Dr. Niti Paul who joined for 5 minutes. She was the chief guest today also.
I know. I mean, immediately after your PregaTalk, she joined.
When she joined you, yes. Okay, thank you very much. Let's go back to Dr. Rajiv Chawla, sir.
Yes.
Yeah.
Thank you. So when it comes to management of hyperglycemia and pregnancy, we all know that insulin remains the gold standard. It is the safest option. So I think it is our duty as a treating diabetologist or physician to prevail upon. And I'm sure most of the patient, once you try to convince them, you tell them the benefits which are going to come, not only in terms of getting euglycemia and also prevention of say sensitization of fetus by hyperglycemia during the pregnancy. So 90% of the females, they will agree for insulin therapy, even if it comes out to be 3 to 4 doses. You very rightly said that these mothers need to be monitored at least from 5 to 7 point program. That means 1 sugar fasting and 2 hours post breakfast, pre lunch, post lunch, pre dinner, post dinner, and number of times maybe midnight sugar, or maybe 12 a.m. sugar is also important to be checked lest she goes into hyperglycemia. So if because of certain reasons, logistics reasons, mother cannot take insulin, or they are say sort of staying at rural places where they cannot get insulin regular basis, so then of course we may agree and we may start them on metformin. Metformin has been approved by Ministry of Health, Government of India, and it is also in current guidelines which you mentioned, 2023. All of us, we are co-authors in that guidelines. There we said that metformin has been found to be safe, and as sir always says that from conception to confinement, it is absolutely safe drug, and a lot of evidence over last 20 years has come that metformin has been found to be absolutely safe in all the clinical trials. There are certain situations where you cannot give metformin, and again, in addition to metformin, or maybe you have to stop metformin and you have to come back on insulin. So insulin remains the gold standard. Metformin option can be explored if patient is not keen or not able to take insulin. Other than that, there is no drug. When it comes to sulfonylurea, current drugs like SGLT2 DPP-4 or GLP-1 receptor agonist. These drugs are absolutely not for pregnancy because there is no safety data, and many animal studies have said that these drugs could be teratogenic. So once it comes to therapy in pregnancy, I think we must prevail. It has to be insulin, 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 and certain situation where patient cannot take, they can be given an option of being on metformin. Especially after 12 weeks, it is found to be absolutely safe.
Yeah, thank you, sir. And now, Shalini, we have come to the end of the trimester. Now that's a due date. Everything is all done, and during what I feel neonatal complications are already covered by Hema. So we'll go for the postpartum follow-up. Now, these women who have
One thing.
yes.
One point which I wanted to bring about is before we leave the pregnancy part is that even if a diabetic has become pregnant, if her HbA1c is slightly higher and all, yes, we know there are increased chances of congenital malformation, etc. But that does not mean that a termination is advised. We have enough methods like sonography and other biochemical methods to find out if the baby is normal or no. So that is one important message, that diabetics firstly should not become pregnant until the HbA1c is below 6.5. But if diabetics have become pregnant, think twice before advising abortion, or they should undergo abortion, because it's important. But yes, the rate of congenital malformation is high, and if the HbA1c is very high, it has as 30%, but then 70% of the fetuses could be normal. So you have to rule that out before we advise a termination in the first trimester.
Very valid point to that. And also one point for you, before I go to Shalini for the postpartum follow-up. Many of the OBGY, not OBGY, but many of the people with diabetes and women with GDM have a perception that once you've got GDM, it has to be only cesarean section. So that's again a myth amongst them. So can you just say a word on this?
Oh, yeah. See, many a times we do this because, see, as obstetricians, we say that it is better to interfere at 38 weeks or at 39 weeks. If the diabetes and the sugars are very well controlled, then we can wait till even 39 weeks. But honestly, we've had problems after 38 weeks when we find there are incidences of sudden stillbirth or fetal distress, stuff like that. So we encourage, or at 38 weeks, we discuss delivery with the patient. And if the patient is willing, then it depends on the baby weight, the position of the head, how easy the induction will be. But most of the patients can be induced, and we do induce them and give them a vaginal delivery. But if it's a difficult induction, or if the sugars are very high, patient is on 3-4 doses of insulin, sometimes to induce such a patient becomes more of a problem, and it is safer for the patient to undergo an elective cesarean section where everything is under control. So it would depend on how the sugars are. And if the sugars are very high, sometimes we have to interfere very early at 37 weeks also if the fetus is showing some distress. So it would all depend upon how the patient's condition is and how the patient's presentation and pelvis is when we decide whether we should do a Caesar straight away, or we should allow the patient to go into labor and wait. But generally, if they don't go into labor at 38 weeks or so, we say, okay, maybe it's a good time to deliver you now rather than keep waiting.
Yeah.
Unless the sugar is absolutely under control.
Thank you, Dr. Uday. Shalini, now we have very few, hardly 5 minutes left to get the whole program concluded. What about the precautions to be taken, and how is the women to be followed postpartum? So during lactation, and some word on breastfeeding. So postpartum follow-up and breastfeeding for these mothers. Yes.
Okay, sir. So if it is somebody who's already got pre-gestational diabetes, that means type 1 or type 2, obviously after delivery, insulin dose requirement is going to come down. So that is where she has to do self-monitoring and accordingly reduce her insulin doses almost to the tune of 20 to 40% reduction we see in insulin doses. Till she is lactating and feeding the baby, if it is a type 2 mother, then obviously again tablets cannot be given except metformin. So for glycemic control, she can take metformin or insulin to have good glycemic control. Once she stops lactation, she can be switched to the oral drugs of diabetes according to the choice of her doctor. Of course, if it is type 1, insulin continues and she just has to go back to the non-pregnant targets. Now, if it is gestational diabetes, So in 80% patients, we see that once the baby is delivered, placenta comes out, diabetogenic stress hormones are gone. So obviously the sugars come back to normal. But the risk for future diabetes continues. So this is the woman who should be clearly told that she has to keep checking her glucose levels, at least, now we say on the third day, even before she gets discharged. You can do a glucose test and see if there is pre-diabetes or remaining diabetes. And then 6 weeks post-delivery or 6 months or every year, she should actually do a 75-gram oral glucose test to see if there is any diabetes coming in. She has to lose the gestational weight that she has gained. Exercise and healthy eating is important, because while she is pregnant, she will follow all the instructions you give her. She will be very careful with her diet, she will be very careful with the exercise, she will be checking her sugars, everything. Once the baby is out, the sugars are normal, so they have a false sense of security that now it is gone. And once they get busy with the baby, time for exercise is not there, eating on time disappears. All the Indian diets that we give, halwa and all those things, sweets and everything, that she's delivered, so the gestational weight she will not lose, and then she'll keep on gaining weight. Exercise goes for a 6, diet goes for a 6, lifestyle gets completely disturbed, she keeps gaining weight, and then she turns diabetic. So, GDM, from one pregnancy to the other, she can again get gestational diabetes. Otherwise, even before she plans the second baby, she may already turn diabetic. So that is where regular follow-up is very important. Glucose monitoring she must do. She must continue with her diet as much as possible. Of course, glucose targets become the non-pregnant targets, but but for conversion for GDM to diabetes, prevention is still possible if she is able to lose weight and watch her diet and exercise well. So I think it has to be a continuous ongoing process, and she must come back for a GTT, preferably at 6 weeks, post delivery. And then once a year, every year, she should definitely be screened. And before planning the second pregnancy, she has to come back to you, like you said, for getting a tick that she is now fit for pregnancy. Again, getting glycemic control back to 6.5 is very, very important, and the entire preconception pathway before she gets pregnant the second time.
I'd like to just add one thing here, Dr. Sunil and Dr. Shalini, that now we are talking of screening in the postpartum period as early as day 3.
Yes,
6
day
weeks
3.
and
That's
6
what I
months was
said.
the standard
That's
practice
what I
because
said. Day 3 and
yeah,
then 6 weeks and then
and
every year.
and we have one publication again with Dr. Picky where we said that if you intervene at 3 days and then followed by 6 weeks and 6 months, outcomes are much better. And me along with Dr. Hema, we wrote a editorial in IGGDC talking about pregnancy as a window of opportunity for intervention for prevention of NCD, subsequently in the mother also. So if we do a early screening at 3 days, we are sure that before she goes back, we have already screened and she does not carry hyperglycemia anymore.
I feel so we have covered almost everything. Kavita, I want to say something about lactation and diet during that
Yes.
period. Yeah.
Yes, so of course, again, diet is very important during lactation because again, we need to have an increased amount of calories. So around 600 calories is increased during the lactation. So 0 to 6 months and even 6 to 12 months. There is also an increase in some amount of proteins and fats. And here we need to also focus that even the micronutrients, so your calcium, iron, folate has to be given pre and even the post partum as well. And again, the galactogod foods are usually given for postpartum, usually for the women who are not able to breastfeed their child. So maybe these foods can be your dark green leafy vegetables, your nuts, your even garlic, papaya, green raw papaya is usually given. So all these can be given to the lactating mothers. And of course, and they have to get back to their normal BMI within a period, maybe after the lactation period is over.
I feel with this, we can stop here. And one final message is that during breastfeeding, there is a chances of going into hypoglycemia. So you have to be little careful. You should be having your proper meal before you breastfeed the baby. I feel with this, I stop here. I presume that we already exceeded the time. Final message usually we take, but I personally feel everyone has already given their final messages. I don't need to take another final message here. The only thing is that always, if you're attending this particular program, see to it that you can further propagate this education to the needy around you, across you, and you will be able to do a wonderful social service by protecting future generation through educating them and empowering them on pregnancy diabetes. So as a medical professional, as an educator, as a paramedics, as a social worker, whatever you are joining this particular program, my appeal on behalf of all the speakers here who are actually representing the whole country here, whereas Mumbai, Delhi, Chennai, UK, so an IDF global. So we have base in Ahmedabad. So practically everyone is in Bangalore. So whole India is being represented here, and we all appeal to all of you to please propagate this knowledge to practically all childbearing age women, so that we can really do wonders for protecting our country from developing diabetes and obesity and non-communicable diseases in their future life. So with this, I stop here. Thank you very much once again, all my faculties. Wish you all a very, very happy World Diabetes Day. We have done justice. We have done one morning program on Vivid Bharati, All India Radio, on World Diabetes Day, and evening we have this PregaTalk, and we're trying to get connected to people around. With this, I stop here.
Sunil, Dr. Kavita,
Thank you.
everyone.
Thank you very much.
Thank you so much, sir. Thank you.
Thank you,
Thank you.
everyone.
Sunil, and
Thank you.
wonderful.
Bye-bye.
Thanks. Great
Thank you.
Shalini, great
Thank
Dr.